Well, we still call it Peyer's patches, just in case you had doubts. It is the lymphoid tissue, but also in the bronchi and in the lung in general, the mucosa-associated immune system is very critical. In any event, we will discuss in this first part proteinuria conditions in general. Interesting over the years, I can tell you is that the glomerulus is a very unique microcirculation, in which the arteriolar half is segregated from the venular half of the regular microcirculation. And what you see here actually is the arteriolar half of the microcirculation in the kidney. The other half, the venular half, is of course represented by the peritubular capillaries. And therefore, you have a very unique system in which the arteriolar half is segregated from the venular half by an efferent arteriole. And so the glomerulus is unique not only in its physiology, the pressure is much higher in the glomerular capillaries than any other capillary in the body, but also because of its differentiation by the various cells allows it to convect a lot of fluid, orders of magnitude more than any other microcirculation. For example, compared to the brain, the amount of fluid convected per unit surface area and per unit time is about 5 orders of magnitude higher than in the microcirculation in the brain. And here you see the physiology of the glomerular capillary. The pressure is much higher than any other capillary in the body, and it reaches equilibrium, the pressure difference between the colloid-oncotic pressure in yellow and the hydrostatic pressure difference reaches equilibrium, at which point the filtration at this point ceases. Whether in humans we reach this equilibrium or whether the entire capillary in the glomerulus filters, the entire length of the capillary filters is not entirely clear. What you don't see in the glomerulus is this venular half, the venular half where the pressures are inverted, where reabsorption of fluid takes place, and that obviously takes place in the kidney at the level of the peritubular capillary. The glomerular capillary is extremely stressed under normal circumstances, not only because there is a tremendous amount of fluid, orders of magnitude higher than any other capillary going across the capillary filter, but also because the amount of fluid that goes that flows along the capillaries is much, much higher than any other. Remember that the entire blood flow that goes through the kidney, which is equivalent to the blood flow that goes through the brain per minute, has to first go through about 30 grams of glomeruli. So the same amount of blood flows a minute through the 1,400 grams of brain compared to about 20 or 30 grams of glomeruli. And then, of course, it goes into the rest of the parenchyma of the kidney. And therefore, the shear stress on the surface of the endothelium is orders of magnitude higher than in any other capillary. And not surprisingly, diseases such as thrombotic angiopathies manifest themselves first and foremost at the level of the glomerulus, giving you the hemolytic uremic syndrome, for example. Well, pertinent to the talk on proteinuria, when you look at the diseases that are predominantly proteinuric, and most importantly, of course, nephrotic, the diseases affect predominantly the distal portion of the capillary of the glomerular filter, namely the visceral epithelial cell or the podocytes. Whereas inflammatory lesions that are characterized by hematuria and an active sediment usually affect the endothelial side, the inner side of the capillary wall. And inflammation and thrombosis go hand in hand. Many diseases that are hematuric with inflammation also have a certain degree of thrombosis, and vice versa. Diseases that are primarily characterized by thrombosis because of complete failure of the endothelium, are also associated to some extent with a certain degree of inflammation. So when you think of proteinuric conditions, think of podocyte diseases, distal diseases. And this is because under normal circumstances, the flow of fluid, the convection happens through numerous channels through the various filtration slit diaphragms that exist at the level of the podocytes. Under these circumstances, negatively charged elements in the endothelium are capable of reflecting back the albumin molecule so that albumin does not even penetrate the filter and cannot be convected into the urinary space. This happens, the hydrodynamic happens completely when you have podocyte injury that is characterized by fusion or effacement, but also by defects where the filtration slit diaphragms are lost completely. And these areas can be expected to have an increased convective flow because you remove the third resistor of the capillary wall. The first resistor is the endothelium, the second is the GBM proper, and the third resistor is the filtration slit diaphragm. When you remove that, you have less resistance, and therefore, with an increased capillary pressure that is usually accompanies usually the nephrotic conditions, you have an increased convection of fluid across. And under those circumstances, the negatively charged elements in the proximal layers of the capillary wall cannot reflect back the albumin. The albumin gets convected across these defects of the podocyte and contributes significantly to proteinuria. When this defect is universal and affects every nephron will be salt retaining because the proteinuria in the distal tubules, the protein in the ultrafiltrate causes upregulation of sodium channels, and therefore every nephron is salt retaining, and therefore the patient has the full nephrotic syndrome with edema. If you only have defects on one side of in the kidney, one kidney is only damaged, like you can do experimentally, those animals do not develop nephrotic syndrome. Even though the proteinuria is nephrotic range, the other half of the nephrons that are non-proteinuric will handle sodium normally, and therefore there is not going to be salt retention and therefore not edema under those circumstances. So the structural abnormalities shared by all nephrotic conditions is a diffuse damage or diffuse simplification, also called fusion, of the foot processes of the glomerular epithelial cells. And this diffuse effacement happens under three morphologic patterns of injury. When there is minimal change, when there is focal, idiopathic focal, some form of focal and segmental sclerosis, and usually in membranous nephropathy. Yes, also in diabetes in the late stages do you have diffuse podocyte injury or failure, and also in amyloidosis you can have severe injury when the amyloid becomes diffuse. At that point, the patient becomes nephrotic. So epithelial cell injury is the hallmark of the nephrotic syndrome. This is a 3-month-old baby boy, developed anasarca within the first few days of life. He was managed with reasonable success by conservative means. His urine showed 4+ protein, and his serum albumin was less than 1 gram per deciliter. He underwent bilateral nephrectomies at this time to improve his growth and development because the diagnosis was made. And you see in this particular newborn, you have very prominent podocytes because the glomerulus is relatively small and therefore a lot of cells. We are born with the number of podocytes that we need for life, and therefore they are very concentrated. So the glomerulus looks pretty normal by light microscopy. This is a silver stain. Here you have the electron microscopy, and it shows not only the prominence of the podocytes, but it shows also that there is no interdigitations left here. There are no intervening filtration slit diaphragms between adjacent foot processes. And those few areas where two cells become together, there's a tight junction rather than a filtration slit diaphragm. So this baby is born without filtration slit diaphragms and is nephrotic. You would think that a filter like this with a continuous epithelium will be more resistant to the convection of protein. Yet what we don't see very often in these shots is that the epithelial cell can be missing completely, as I will show you in other cases. So this patient has a defect of one of the proteins that constitutes the filtration slit diaphragm, namely the nephrin. These filtration slit diaphragms are not generated in these babies. They are born with a nephrotic syndrome. And currently the only way of helping them is by doing the nephrectomy to allow the baby to grow and eventually receive a transplant. So there are many genetic abnormalities that you recognize. Here are the more important ones. Defects in the gene that encodes for nephrin, that encodes for protosin, phospholipase C epsilon is another one that causes, and Wilms tumor gene, the WT gene, that also causes a diffuse podocyte damage, leading to nephrotic syndrome in the newborn in general. This other baby was born at 39 weeks gestation to a 32-year-old G3P3 mother. Triple screen, remarkable for high AFP, leading to several prenatal ultrasounds and amniocentesis. The prenatal ultrasound showed pericardial effusion and possible aneurysm of a primary septum. Normal kidneys. The amnio demonstrated XY karyotype in this baby girl. Birth weight was 6 pounds and 4 ounces, and the rest is there. And at this point, what you saw on the nephrectomy eventually is the prominence of the mesangium, but also collapse of capillaries, similar to in adults what we call a collapsing type of glomerulopathy. Also here you see diffuse effacement on the transmission electron microscopy. You see diffuse effacement of the podocyte in this baby with a Wilms tumor, was born with a defect. Other genetic abnormalities present later in life. These patients are not born with a nephrotic syndrome. They develop slowly progressive proteinuria over 3 or 4 decades. And these patients have an autosomal, usually an autosomal dominant defect of other proteins. Many of these proteins are constituents of the microfilaments and microtubules, alpha-actinin. The TRPC6 is another, and the IFN2 is another gene that encodes for proteins that are relevant for the function of the podocyte. However, the disease is age-dependent. Penetrance is age-dependent. This is an example of a 45-year-old man with a family history of renal disease, presents with advanced CKD at age 45, as you can see. He has albuminuria, he has proteinuria that eventually reaches above the threshold that you consider characteristic for the nephrotic syndrome. He developed only edema much, much later in life. And what does the biopsy show? It shows an area of segmental sclerosis. And segmental sclerosis is just a lesion. And you can see here that the podocytes are reasonably well preserved. The interdigitating foot processes are effaced only in some segments of the capillary wall. Other segments are perfectly okay, at least at this time. So here you have a focal disease, a much more restricted disease, but it's also genetic. And examples of these types of injury, genetic injury that leads eventually to failure of the podocytes and focal and segmental sclerosis are listed here. There are many also patients that develop, that don't have a family history in which the disease is not autosomal dominant, but rather autosomal recessive, and up to 26 different genes that encode different proteins of the podocyte have been reported more or less to date that can give you an autosomal recessive podocyte injury that obviously will not appear to you as a familiar disease because it's autosomal recessive, and it appears as if it were sporadic. And only molecular analysis of the various genes that potentially can give you progressive proteinuria, and yes, focal and segmental sclerosis on biopsy can be detected. This is a list of those genes. In blue, the autosomal dominant ones, and in red, the autosomal recessive ones. And you can see that this is becoming very complex. Of course, many of these diseases are rare, but we don't know how many of these genes are relevant in polymorphic form to influence the course of proteinuric conditions that we consider presently acquired forms. So here is a tentative attempt to organize all these diseases of the podocytes. We have diffuse genetic podocytopathies that are present usually with a nephrotic syndrome very early in life, if not at birth. And the classic example is the Finnish type of the congenital nephrotic syndrome, but also the steroid-resistant nephrotic syndrome due to podocin belongs here. WT1 is another example of these diffuse podocytopathies. The autosomal dominance that I showed you, the case of this man at middle age that developed progressive proteinuria, belong to the focal lesions. These patients are not born with a diffuse podocytopathy, but the podocyte is injured genetically, is insufficient to maintain the normal structure, and with time, they develop podocyte injury, progressive proteinuria. In the acquired, which is what we will discuss next, you can also divide the proteinuric diseases with diffuse podocyte injury. The classic example is minimum change disease, but also membranous nephropathy is another one in which the damage is due to immune complexes. And focal or acquired podocytopathies, for example, the adaptive focal sclerosis that ensues in patients with metabolic syndrome or after nephrectomies or when patients are born with fewer nephrons, such as unilateral agenesis. So let's go through the acquired, the more common forms of epithelial cell. But remember that behind many of these seemingly acquired forms may be polymorphisms or weaknesses at the level of the podocyte that may explain the various evolutions that patients take when they develop an acquired form of podocyte injury. Minimal change disease is a diffuse podocytopathy. In general, presents suddenly with sudden onset of the nephrotic syndrome. The second group in this disease is idiopathic or primary focal and segmental sclerosis. Here you develop eventually progressive proteinuria and progressive renal failure very often because this group of patients tend to respond less well to therapy. And collapsing glomerulopathy is another form of can be a diffuse podocytopathy. Usually the morphology is pretty normal in minimal change disease. The glomeruli look normal. Very often patients have also tubular injury because they can present with acute kidney injury. And both children as well as adults can present with minimal change disease, and the presentation is also acute kidney injury. The glomerulus under normal circumstances in minimal change disease looks perfectly normal. The basement membrane is of normal thickness. The cellularity of the glomerulus is normal. And as I mentioned, occasionally you see tubular changes associated with sudden onset of minimal change disease. The silver stain is useful to differentiate it from membranous. In membranous, you see basement membrane spikes, thickened basement membranes on silver stain. In this case, the basement membrane is delicate and thin, without spikes, without defects or craters, as we call them. We have observed for about 20 years now that patients with minimal change disease, or a certain proportion of them, a great proportion, have this very fine, what I call dusting of IgG over the podocytes. And so there is an IgG that decorates very often the surface of the podocytes. It's not at the level of the basement membrane like the IgG that you see in patients with membranous nephropathy. And this will eventually lead, I hope, to publication. We think that minimal change disease is also similar to membranous nephropathy, an antibody-driven process, and you will probably hear more about it in the course of the next year. The consequence of whatever is binding to the podocyte is a diffuse effacement of food process. You can see here every capillary has a continuous layer of podocytes. You probably cannot see it at low power, but here you have a higher power of a case of minimal change disease. Diffuse effacement, diffuse disappearance of the interdigitations, and with them the filtration slit diaphragms, which we think is driving this process in general. You can see at higher power how the podocytes have become lifted off, where the defects, where there is no filtration slit diaphragm. These are the areas here highlighted by the arrow. These are the areas that are hyperpermeable to water, and through that ultrafiltration flux, you drag along proteins, including albumin, non-specifically, into the urinary space. So podocyte failure, a diffuse podocyte failure, results in the nephrotic syndrome, and very often, as in this example, a damage to the tubules, probably from hypovolemia, from ischemic injury. Patients often develop acute kidney injury with an elevation of the serum creatinine in the setting of sudden onset of the nephrotic syndrome. So the clinical conditions, the classic form, of course, is what we call idiopathic minimal change disease or lipoid nephrosis or nil disease. But remember, many of these patients can also have an underlying condition that triggers the appearance of this form of injury. And they can be associated, these triggering factors can be drugs, hypersensitivity. There can be early infections such as HIV. Some patients have also early parvovirus infection, developed that. Sometimes there's an underlying lymphoproliferative disorder that triggers this disease. You treat the underlying lymphoproliferative disorder, the minimal change disease goes away. If the lymphoproliferative disorder reappears, you will have reappearance of the nephron. And then don't forget that patients with other diseases can develop superimposed minimal change disease, and that is the case in patients with lupus. They can develop minimal change disease, again, an antibody-driven process. Patients with IgA nephropathy can have sometimes superimposed minimal change disease, in which case they present the sudden onset of the nephrotic syndrome. And more difficult to diagnose sometimes is patients with diabetes that develop, in addition to the diabetes, a low progressive proteinuria, all of a sudden a stepwise rise in the serum creatinine, and they develop a superimposed minimal change disease. The biopsy shows usually relatively minor changes for the diabetes, but diffuse effacement of food processes. Not always is it easy to differentiate the diabetic changes, which affect the podocytes, of course, and the superimposed minimal change disease. But in general, the clinical situation is also telling you a lot. When the patient all of a sudden developed the nephrotic syndrome in the course of an otherwise normal evolution of diabetes with a pre-episode proteinuria of a few hundred milligrams, and all of a sudden they present with 10 grams of protein, you know there is something superimposed on that, together with a hypoalbuminemia and the appearance of the edema. Focal and segmental glomerulosclerosis is a wastebasket. It is, at least clinically. It comes in various morphologic flavors that are completely irrelevant. Whether the patient has one or the other of these variants is irrelevant. The relevant thing is does the patient have a steroid responsive in a way, or chemotherapy responsive disease, or does the patient have an irresponsive disease that does not respond to the conventional therapy that we apply to patients with minimal change disease. And therefore, I prefer this definition: idiopathic when the patient has diffuse effacement of food processes, a diffuse podocytopathy. Secondary or adaptive is a focal podocytopathy and therefore not associated usually at the beginning with the nephrotic syndrome. Segmental scarring after a vasculitis, after an IgA nephropathy, after a lupus nephritis, you can have segmental scarring that should be differentiated from the idiopathic variant of focal and segmental sclerosis. And we already discussed familial focal sclerosis. These are all different ways in which different diseases, completely different in its pathogenesis, present, yes, with focal and segmental sclerosis. And focal and segmental sclerosis is nothing but an irreversible failure of the porocyte. Those areas that become sclerotic, the porocyte have not recovered, and therefore that part of the glomerulus has become obsolescent. And it can be on the basis of a diffuse porocytopathy, like in idiopathic focal and segmental sclerosis. Now here you have an example of a patient with relatively sudden onset of the nephrotic syndrome. The biopsy shows a well-preserved parenchyma. There is not much atrophy here, and you will see the difference with the other forms of focal sclerosis. And the higher power shows the classic example of a segmental area of obsolescent capillaries with hyalinosis. This part of the glomerulus is obsolescent. This is irreversible porocyte failure. Yes, the rest also has porocyte failure, but it hasn't undergone complete collapse. It is not collapsed at this point. Very often, these lesions are associated with prominence of the porocyte and collapse of the capillary. Sometimes this affects predominantly the tubular pole, and this area of the tuft, which shows early focal and segmental sclerosis, is herniated into the proximal tubule, and then it has been termed tip lesion. Tip lesion is usually the morphologic counterpart of a porocyte failure. Very often behind this is a diffuse porocytopathy, yes, with early focal and segmental sclerosis. This part of the tuft will probably not recover and will probably undergo complete sclerosis. Very often these areas accumulate IgM and C3, and so by immunofluorescence you find segmental IgM and C3, not because these are relevant to the pathogenesis, but because these are large plasma proteins that accumulate in the areas of hyalinosis. Any patient with hyalinosis anywhere will have IgM and C3 staining. This can be in the vasculature in patients with diabetes, for example. You have hyalinosis of the arterioles, which will stain with IgM and C3 as a non-specific marker for insudated proteins. Now, in this case, you have, and you cannot see this very well at low power, you have a diffuse damage of the porocyte. Here you can see it. The entire surface of this capillary is covered by damaged porocytes without intervening filtration slit diaphragms or intervening foot processes. And here you see a more dramatic form of the porocyte injury. The porocyte is becoming detached from the basal membrane. Here you see complete lack of porocytic surface cover of this part of the capillary, where it begins to accumulate hyaline material in the subendothelial space, which we call hyaline. So in this case, the patient has a diffuse porocytopathy, hence the nephrotic syndrome, hypoalbuminemia, and edema. And yes, focal lesions that we call focal and segmental glomerulosclerosis. So remember that the proteinuria basically is a measure of the failure of the porocyte, the failure of the specifically of the filtration slit diaphragms. And this failure can be focal or it can be diffuse. In the case of diffuse failure, every glomerulus is proteinuric, and therefore you have the nephrotic syndrome. Sometimes the segmental obsolescence is due to scarring. For example, a patient with an ANCA, when it recovers, has proteinuria 2-3 grams, and the biopsy will show not the active lesion, but the healed lesion. And this is what a healed glomerulitis looks like. You have, yes, type 4 collagen, the darker staining material is collapsed capillaries, but then you have the paler staining lesion is scar collagen, the same collagen that deposits in cirrhotic livers or that replaces eventually the myocardial infarct. This is a scar. This is not due to primary podocyte failure. This was an inflammatory lesion at one point, like you see here, a focal necrotizing and a crescentic lesion. Eventually, it leads to focal and segmental scarring. So when you get the report back that says focal and segmental sclerosis, because this will be lumped into this wastebasket of focal and segmental sclerosis, you have to ask yourself the question, and your pathologist, is this really the conventional focal sclerosis associated with heavy proteinuria and nephrotic syndrome, or is this potentially a scarring, especially if you have a history of a patient that suffered in the past a form of focal glomerulitis? Obviously, healed focal and segmental sclerosis, or focal and segmental scarring, as I like to call it, can be seen in IgA, various vasculitides, patients with lupus after they heal a focal proliferative lupus nephritis, or post-infectious glomerulonephritis, all can lead to scarring. And this has a different meaning than the idiopathic focal and segmental sclerosis, as you know it from the textbooks. Sometimes more difficult to differentiate from the idiopathic variant is the secondary or adaptive form of focal and segmental glomerulosclerosis. Here you have an example of focal and segmental sclerosis in 1 out of 4 glomeruli that are huge compared to normal glomeruli in a patient that was born with unilateral renal agenesis, developed some obesity in his middle age, and eventually developed nephrotic range proteinuria, 3, 4, 5 grams of proteinuria associated with hypertension. And the biopsy shows this. And again, indistinguishable by light microscopy from the idiopathic variant of the disease, but electron microscopically, you can see that the foot processes are reasonably well preserved in many, many capillaries. Obviously, if you were to take this glomerulus with this much podocyte injury, with irreversible lesions, and would do electron microscopy, of course you would find a lot of fusion and effacement of foot processes. So in this case, it's very important to choose the best preserved glomerulus for electron microscopy. I would choose, for example, a glomerulus that looks like this or like this. I would not choose to do electron microscopy the glomerulus where you know the podocytes are going to be irreversibly damaged. And therefore, in these diseases, the better preserved glomerulus needs to be examined by electron microscopy. Here's another example of a patient with chronic pyelonephritis and reflux nephropathy. This is characteristic up here for chronic pyelonephritis. If you look at the preserved area of the parenchyma, you will find invariably areas of segmental sclerosis. This has nothing to do with idiopathic focal and segmental sclerosis, yet it presents the same face, focal and segmental sclerosis with hyalinosis. Again, relative preservation of foot processes for many areas. And so you can see a number of diseases, and the more frequent these days is, of course, obesity associated focal and segmental sclerosis. You can see up here the kidney, the cortex is reasonably well preserved, but many, many glomeruli have this lesion of focal and segmental sclerosis with hyalinosis. If you look at the electron microscopy on a reasonably well preserved glomerulus, the foot processes are perfectly well preserved. This is not a diffuse podocytopathy. So I have shown you a few examples of this adaptive form of focal sclerosis. Adaptive because it ensues with hypertrophy of the glomeruli, with progressive loss of function. You have more and more compensatory hypertension in the capillaries, and this compensatory morphologic compensation as well as functional compensation to increase the GFR leads to further damage and closes a positive feedback loop by which you develop progressive kidney disease. So how do we differentiate this? Well, I have shown you how to differentiate it morphologically. Not every place you can do electron microscopy, and I realize that, but electron microscopy is a very important component of the analysis of a kidney biopsy. And I feel very strongly that if a patient undergoes the risk of taking a kidney biopsy, it should be analyzed with all the possible means that we have to get to the bottom of the cause. So idiopathic focal and segmental has sudden onset of the nephrotic syndrome with edema, hypoalbuminemia, and the rest hyperlipidemia. In general, no history of prior kidney disease. It's a disease that presents like minimum change disease, sudden in onset. By morphology, you have a normal size glomeruli, you have diffuse effacement of the foot processes, and you have no significant parenchymal atrophy, at least at the beginning of the disease. Of course, this disease is progressive or can be progressive, and therefore, eventually, if you come late with a biopsy, you will find significant parenchymal damage. Adaptive focal sclerosis, slowly progressive proteinuria in general, without edema, at least at the beginning, without hypoalbuminemia. History of prior kidney disease. In women, it's very important to find out if there were pregnancy-related complications. Preeclampsia is often a vascular form of disease that leaves behind lesions in the kidney, or the patient has a tendency of procoagulation, and therefore, eventually, the kidney is damaged due to the underlying thrombophilia or procoagulant state in these patients. Very important to find out if women had preeclampsia, when 20 years later they develop slowly progressive proteinuria and eventually renal failure. So this is a very important aspect to ask for. And epidemiologic studies have shown very clearly that the more preeclamptic episodes a woman develops earlier in life, the more likely it is for her to become a chronic kidney disease later in life, and often 20 years down the line. These patients have glomerular hypertrophy as an example of the adaptive changes on biopsy. The foot processes are largely preserved, and especially important is to look for and preserve glomerulus. And very often there's a history, as I mentioned, of pre-existing kidney injury, chronic pyelonephritis, reflux nephropathy as a child, or as I mentioned to you, preeclampsia in women. Morphologically, idiopathic focal sclerosis is characterized by diffuse effacement of foot processes, whereas in adaptive focal sclerosis, the foot processes are largely preserved. Are there cases that are more difficult? Absolutely. There are always the outliers where morphologically it is difficult to differentiate them because sometimes the damage of the kidney is too far advanced for us to have a relatively preserved glomerulus to examine ideally under the electron microscope. Collapsing glomerulopathy is yet another form of diffuse podocytopathy, and it comes these days. I think we need to differentiate those in non-African Americans in which there is a trigger, an important trigger, and this is usually HIV infection or other serious viral infections, or in patients with the APOL1 risk alleles, the genetic form, if you want, of the collapsing gene. Collapsing gene is characterized by prominence of the epithelial cells, and here you can see very prominent epithelial cells without this constituting a crescent. You have protein reabsorption granules, vacuolated. You can see the vacuoles here. This is a massive injury acquired to the podocytes with collapse of capillaries and prominence of the podocyte in this. Here you have a normal glomerulus on the left and a glomerulus with collapsing glomerulopathy on the right. And you can see the capillaries are all closed. The lumina that you see on the left are completely gone on the right, and you have the prominence of the podocyte. When it is this dramatic, it is very easy to diagnose. Not always are the cases quite as dramatic. This is why I took this picture to show you. Here you can see with albumin that the protein reabsorption granules take up albumin, and this is an epiphenomenon, of course. The podocyte injury results in this uptake. And the electron microscopy shows complete collapse of capillaries. So you see 2 or 3 capillaries completely collapsed, and you no longer recognize the podocytes as such. This is just a mass of a cytoplasmic material of damaged, probably severely damaged, probably necrotic podocytes. The notion of podocyturia applies to this. You can easily see how podocytes can swim off, become detached, and appear in the urine sediment, and people actually have looked at this as the number of podocytes. You get podocyturia in diabetic also. Diabetes is a condition in which podocytes little by little get lost from the capillaries. When you have tubular reticular inclusions in the endothelial cell, we strongly suggest this patient must have a viral infection, and HIV is often the infection that triggers collapsing GM, especially in African Americans with risk alleles of APOL1. Here are the conditions that are associated usually with collapsing GM, but as I mentioned to you, in rough terms, we can recognize this in non-African Americans secondary to severe systemic infections or systemic conditions, such as hemophagocytic syndrome, for example, very often related to viral infections. And in African American, it is usually due to the inherited risk alleles of the APOL1. And finally, just very briefly, since you have a full lecture on membranous nephropathy, also membranous nephropathy is a diffuse podocytopathy. In this case, we recognize some of the antibodies that are responsible for this. By light microscope, diffuse thickening of the basement membranes, and if you look at this with silver stain, you can see the basement membrane spikes that come off at the right angle from the basement membrane, and then the diagnosis can be made by light microscopy. At least we assume it is. There is diffuse fine granular deposition of IgG and a little bit of complement along the glomerular basement membranes. The immunoglobulins are usually of the IgG4 class, which normally is a very low represented subclass. The other are less dramatic. IgG1, 2, and 3 are less, so dominance of IgG4. And if you stain for the phospholipase A2 receptor in cases in the 70 or 60 or 70% of patients that have this autoantibody, you will find them represented in these deposits. Other antigens are also being recognized these days, so phospholipase is but one of the antigens that can cause this form of podocyte injury. Here, the response is against an antigen that is represented or that is expressed on the basal surface of the podocyte. It has nowhere to go. The immune complex gets shed, the antigen gets shed into the environment, and these immune complexes grow. And in order for the podocyte to retain its attachment to the basement membrane, which is now far away, it generates the basement membrane spikes, which is nothing but basement membrane collagen that is overproduced by the podocyte that is being pushed into the urinary space by the growing subepithelial immune deposit. We know now that this is probably an in situ formation of immune complexes. This has been demonstrated about 25 years ago, that the antigen gets from the circulation, gets to this point. It meets an antigen, a particular antigen, in this case, phospholipase A2 receptor, and forms an immune complex disease. So this is an antibody-driven damage to the podocyte that happens to accumulate immune complexes under the cell membrane of the podocyte. So there are predisposing factors. There are probably HLA predisposition for this. There are probably polymorphisms of the molecule that facilitate this limited form of autoimmunity. In a way, you can look at this as a very simple, like hemolytic anemia, as an antibody against the red cell produces lysis and the red cell dies. Here you have the same. You have an autoantibody limited to the podocytes that leads to, in this case, an immune complex disease because the shed antigen has nowhere to go. It accumulates in the lamina rada externa of the basement membrane. So membranous nephropathy is probably a complement dependent injury of the podocytes by an autoantibody that recognizes a specific antigen on the cell surface, not on the filtration cell diaphragm, on the cell surface of the membrane that faces the basement membrane of the podocyte. We call it idiopathic, but we should stop calling it idiopathic because we now know what the antigen, the target antigen is in most cases. And here you have the few antigens that have been described so far. In membranous nephropathy, we need to still define the antigen in membranous lupus nephritis, and I'm sure we will find some other antigens that can be the target in membranous lupus nephritis. So this is my summary of the nephrotic conditions and the pathology, and hopefully you will have learned some of the relevant issues that you need to pay attention in the biopsies or to ask your pathologist concerning the differential diagnosis of these patterns of injury. Minimal change disease is a pattern of injury. Focal sclerosis is most definitely a pattern of injury that needs to be dissected, and so is membranous, and hopefully in the future we will have more specific therapy for diseases such as membranous. Thank you very much.